Hi guys, Assalamu alaikum. My name is Anis Fatma and I'm a final year medical student, and today we will be studying about abdominal and inguinal hernias. Note that these surgery lectures are compiled from the Irfan Masood and Brilliant Love, and then we have the sliding hernia. Sliding hernias is the type of hernia in which the posterior wall of the sac is partially formed by the wall of the viscera. The thing which is important for us is it is formed by peritoneum, sigmoid colon, and mesentery on the left side. Left side is the one in which heart is present, and then it is formed by peritoneum and cecum on the right side, and sometimes on either side by the portion of the bladder. So bladder could be in the on the left side, on the right side. Peritoneum could be on the left side and the right side, but we need to remember that cecum is present on the right side and sigmoid column is present on the left side. The clinical features is sliding hernia is common in males, and it is more common on the left side. It is present in men usually which are who are older than 40 years of age, and there are no clinical findings that are pathognomic of the sliding hernia. The hernia looks like the inguinal hernia, could be direct, could be indirect, etc. Treatment is operation is indicated, and it has a very good prognosis. And then comes the strangulated inguinal hernia. Strangulated is the one in which blood supply is compromised, and strangulation is more common with the indirect inguinal hernias which were coming out of the deep inguinal ring. Strangulation occurs at any time during the life and in both sexes, could be in males, could be in females, and the constricting agent is mostly the neck of the sac, the external inguinal ring in children, and adhesion within the sac. Contents of the strangulated hernia would be small intestines and omentum, etc. And it is more common in girls during the infancy, and most common content in the girls is mostly ovaries. So strangulated hernia, which is caused by the neck of the sac, in which blood supply is getting compromised, it is more common in girls during the infancy. Most common component are the ovaries and the small intestine. Treatment would be you need to resuscitate the adequate fluids to the child. You need to empty the stomach for the decompression via the nasogastric tube. You give broad spectrum antibiotics. You catheterize to monitor the hemodynamic status of the child, and then you have to of course do the emergency herniotomy to release the contents of the hernia out of that sac. Complications of the inguinal surgery could be divided into early complications and late complications. The early complications could be the pain at the hernial site, could be the bleeding from the hernial site, or urinary retention because the abdominal wall would develop the rigidity, and anesthesia related complications. Late complications at the suture at the inguinal surgery site could be the seroma formation, or the wound infection, or the hernial recurrence because you have also created a defect in the abdominal wall, or chronic pain. The chronic pain is defined as pain which is present for more than 3 months after the surgery, or the testicular infarction because you might have accidentally damaged the artery to the testicles. We have already talked about that most commonly hernias which get strangulated are femoral hernias because of their narrow necks. So, what is femoral hernia? Femoral hernia refers to the protrusion of extraperitoneal tissue, peritoneum, and sometimes the abdominal content through the femoral canal. This means we have to study what the femoral canal is, and the femoral canal is the medial most compartment of the femoral sheath. So it is located towards the pubic tubercle on the medial side of the femoral sheath. The femoral canal is usually 1.25 centimeter long and 1.25 centimeter wide at its base. The upper opening of the femoral canal is known as the femoral ring. The femoral ring has the following boundaries. There will be anterior boundary, posterior, medial, and lateral. Anteriorly, there is inguinal ligament. Posteriorly, there is the Astley-Cooper's ligament, the pubic bone, and the fascia over the pectineus muscle. So, anteriorly, the inguinal ligament. Posteriorly, there is the Cooper's ligament and the pubic bone. Medially, there is the Gimbernat's ligament or lacunar ligament, and laterally, there is the septum, which is separating it from the femoral vein. As we have already studied about the contents or the boundaries of the femoral ring, which was present on the superior side of the femoral canal, The opening allows several contents to pass through the femoral canal, which could be the fatty connective tissue, the efferent lymph nodes from the deep inguinal nodes, and the deep inguinal node of the cloacae. It is the femoral hernia is more common in males and it cannot be controlled by the truss. It has a higher incidence of strangulation due to its narrow neck. How would the femoral hernia present? It is mostly presents after the puberty and it affects right side twice as compared to the left side. The characteristic features of the femoral hernia is that the hernia is very small, it is non-reducible, it has no cuff impulse. No cuff impulse means it would be present all the time. It often contains the omentum. It may contain a knuckle of the bowel, and if it contains the knuckle of the bowel, it is called as the Richter's hernia. And then we have several differential diagnoses. If we are suspecting a patient is of femoral hernia, we have to rule out the inguinal hernia, safena varix, and several other causes. Inguinal hernia, we are suspecting a patient is of femoral hernia, we need to look at the inguinal hernia, which emerges above and medial to the pubic tubercle, and femoral hernia emerges below and lateral to the pubic tubercle. So you need to know the landmark, which is pubic tubercle. If it is above and medial to it, it is inguinal hernia. If it is below the pubic tubercle and it is lateral to it, it is the femoral hernia. So femoral hernia is more common on the lateral side, while inguinal hernia is slightly medial to it. Then the second differential diagnosis is safena varix, which refers to the secular enlargement of the termination of the long saphenous vein. It disappears completely when the patient lies flat, unlike the femoral hernia. We already looked at that femoral hernia is non-reducible. It has no positive cuff impulse. It means femoral hernia is present all the time, while safena varix would disappear once the patient lies supine in front of you. It has a cuff impulse like the femoral hernia, but it imparts a fluid thrill too, unlike the femoral hernia. Then we have other common DDs, which could be enlarged femoral lymph nodes, lipoma, femoral aneurysm, psoas abscess, etc. Other types of the femoral hernia could be the Legier's femoral hernia, the Narat's femoral hernia, the Clockett's hernia, and the strangulated hernia. The Logier femoral hernia is the hernia through a gap in the lacunar ligament. The hernia has nearly always strangulated. Narat's femoral hernia is when the hernia lies behind the femoral vessels. It is mostly common in the patients with congenital dislocation of the hip. So you need to remember, if there is a dislocation of hip, there will be Narat's femoral hernia, which is present behind the femoral vessels. Then we have the Clockett's hernia. It is the hernia in which sac lies under the fascia covering the pectineus muscle and strangulation is likely. So strangulation is common in all types of the femoral hernia. In Legger's hernia, which is through the lacunar ligament, in Narat's hernia, which is posterior to the femoral vessels, and in the Clockett's hernia, which is posterior or under to the fascia covering the pectineus muscle. Now comes the treatment of the femoral hernia. So, femoral hernia or any type of hernia, the definitive treatment for that would be surgery, and you have to prep the patient before the surgery by emptying his bladder with catheterization of Foley's catheter, and you need to empty their or decompensate their bowel. You need to apply the anesthesia, etc. There are several different types of the femoral hernia operations: the low operation, the high operation, and the inguinal operation. The low operation is called as the Lockwood operation. The high operation is called as the McFD operation, and the inguinal operation is the Lothisen operation. And we are obviously going to look at all of these in the next few slides. The first operation for the treatment of the femoral hernia was Lockwood operation. So Lockwood operation is used for the elective femoral hernial repair. It provides little scope for resecting the compromised small bowel and is therefore avoided in such cases. Like whenever there is emergency case, you would do the Lockwood operation because it doesn't allow you to resect the compromised small bowel. The oblique incision is given 1 centimeter below and parallel to the medial inguinal ligament. For the inguinal hernias, we're giving the incision 1.25 centimeter above the inguinal ligament. While in the Lockwood operation for the treatment of the femoral hernia, we are giving the incision that is 1 centimeter below and parallel to the medial two-third of the inguinal ligament. Remember that. The second type of operation for the treatment of the femoral hernia was the high operation or the McEve-Day operation. It is the most useful and the most commonly used operation for the treatment of the femoral hernia. It is used for the strangulated hernia because it allows us to resect the part of the compromised bowel, and it is the safest approach for an emergency femoral hernia. Remember, the Lockwood operation was for the elective cases, while McEve-Day operation is for the emergency cases, which is either irreversible or with the evidence of bowel obstruction. It is used for bilateral hernias through the fenestrial incision, and vertical incision is made over the femoral canal and continued upward above the inguinal ligament. So what you are doing, you are putting a vertical incision at the place of the femoral canal and you are continuing it upwards towards the inguinal ligament. And if you need to do it bilaterally, you will do the fenestrial incision, and it is the safest approach. It allows you to resect the compromised bowel. It is done in emergency cases. Then we have the inguinal or the Lothocene operation, which is also used in the treatment of the femoral hernia. Again, it is for the elective hernia repair. It is used for emergency cases as well in irreducible hernias where the bowel resection is considered unlikely. Yeah, like you are considering an emergency case, but you think that there would be no strangulation, there would be no compromised bowel, and you won't need to resect it, then you can do the Lothocene operation. The dissection is the same as for inguinal hernia repair, but the transversalis fascia is open to expose the femoral vessels and the canal beneath it. A long skin crease incision of 2.5 centimeter above the medial two-thirds of the inguinal ligament is given. There are three operations for the femoral hernia. The one was low operation, in which you will give the incision below the inguinal ligament, 1 centimeter below the inguinal ligament. In the inguinal operation, or in the operation that was also used for the inguinal hernia repair or the Lothocene operation, you will be giving the incision 2.5 2.5 centimeter above the medial two-thirds of the inguinal ligament. It doesn't allow you to resect the compromised bowel, but it could be done in emergency cases. And then comes the ventral abdominal hernias. We are done with femoral hernia, we are done with inguinal hernias, then the rest of the hernias of the interior abdominal wall are included in the category of ventral hernias. Ventral hernia refers to the hernia of the anterior abdominal wall. It could be umbilical hernia, paraumbilical hernia, epigastric hernia, incisional hernia, parastomal hernia, spigelian hernia, or the lumbar hernia. And the names are very clear in what they might include. The umbilical and the paraumbilical hernia is the herniation is through the umbilical defect or through the linea alba, which is immediately adjacent to the true umbilicus. The risk factors mostly are the female gender, there is obesity, there is multi-pregnancy, which are putting the pressure on the anterior abdominal wall, or it could be the CLD as well. The most important for us are the treatment of the umbilical hernias. Surgery is advised in all types of hernias in adults because of the risk of obstruction and strangulation. Now, if the defect is less than 2 centimeter, you will do the herniorrhaphy like anatomical repair. You won't use the mesh. If the defect is larger than 2 centimeter, you have to do some kind of intervention like Mayo's repair and mesh repair. What is Mayo's repair? Mayo's repair, when the incision is elliptical incision around the umbilicus, that's it. That's what the important part is. Then mesh repair. The mesh may be placed in any of the following planes within the peritoneal cavity. It is a quick repair, but it requires expensive mesh because you are inside the peritoneal cavity, you are in direct contact with the bowel and other contents of the peritoneal cavity. In the retromuscular space, like you are above the peritoneum but behind the muscles, it is very secure, but it requires the expensive dissection. In the extraperitoneal space, it is very difficult to repair because it is difficult to retain the mesh there. And in the subcutaneous plane, which is called onlay mesh, it is the simplest technique, and but it is prone to infection as the mesh is in the subcutaneous tissue. And that's it for today. We will see you in the next lecture very, very soon.